just posted week 4. I thought I'd done it earlier this week. I didn't. But, I know with an exam, you're not going to be doing a lot of anything else. I mean, I'm real. I understand that. You guys put a lot of time and effort into studying. So I knew that even posting it, you're going to say, well, not really look. Remember this week, week 4, I did just post your PowerPoint for you, so you do have it. It's the child's experience in hospitalization, okay? And also it's the discussion question. I did send out some quick notes this morning about just please do your discussion question in case they weren't done, okay? So that you do have those discussion questions. The one thing I can tell you about your discussion questions, they're very relevant. And you doing them, I see them again and again on the exam. So getting them done and understanding instead of just a quick cut and paste will help you a little more, okay? Just giving you hints, into the future. So anybody have any questions to start with? All right, let's
I'm
go
sorry,
over
I didn't get to hear you. When are we going to get our grades?
tomorrow about
Okay.
2:30, 3 o'clock.
Okay, that's fine.
And then I said, anybody who wants to review it with me, you're more than welcome. Make an appointment. I'll work around your all schedule, okay?
Okay.
So here we go. Let's go and do our PowerPoint first. Get it done. A lot of information on it. The one thing I wanted to let you see is, you have PowerPoints, and then on the bottom, you have these note pages. Now, these note pages here are very important because you'll see on some slides, you have some information to let you know. When you print a PowerPoint, I know a lot of you do, print it with note pages. And there is a thing on the print, when you get up to print one copy, it is there with note pages, and these will come up, okay? Because it gives you some great questions about it. I didn't tell you earlier, I don't know why, but I just remembered. So there we go. So children, we think that children and adults, same thing, same experiences. Well, I think we know by now that children respond differently than adults. Adults, you get one sort of diagnosis and they almost act the same, and they're same sort of scenarios. Children are never the same. And I think that's why I worked in pediatrics so long, about 25 years. It's because they're never the same. And I always had to think. They kept me on my toes. So let's go into, kids and what we see. Well, we have children that need to go to a hospital. They have an appendicitis and need surgery, they're going to be staying in. Or they have peritonsillitis, they need to have antibiotics and surgery and hospitalization. Sickle cell, all of those. Acute care hospitalization. Then you have those long-term care facilities. Those are children that maybe need skilled nursing care, where they can't take care of them at home. You don't see a lot of them, but you will see, very rare, you'll see a kid like that. Most kids go home with the parents, and they usually have care coming in to helping them, or they send them to a prescribed pediatric extended daycare. And some of them are excellent. I worked with one as a supervisor for clinicals. We know when you go to an ER, it's urgent care that you need. A urgent care, though, is something that is normal symptoms, sore throat, cough, cold, fever. It's not for those acutely really ill children, just like adults. They just really aren't. They don't have all the facilities to take care of them. But urgent cares are a great thing today, especially the doctor's care. You could get right in. Outpatient clinics, they're, usually outpatient treatments. We know it's doctors' offices. We know there's a lot of research continually going on in pediatrics. I know where I am in Miami, this Nicholas Children's, used to be Miami Children's. They do a lot of research there, and they have a lot of research PhDs and doctors doing their PhDs in research, and a lot of nice stuff is coming out of that. Outpatient surgery, this is what we like to do for our kids, right? We want to do their ear tubes and their tonsils and adenoidectomies and go home the right day. That keeps a child safe, right? And then we could do things at home also. Now, how are you going to prepare a child? Children, remember, you've got to base your care on their responsiveness to care, right? We want to know that what's their developmental level. Let me make sure that I did put on record. I did. I've just all of a sudden had a moment, didn't know if I did. So, number one, on their level, you would treat a 1-year-old different from a 3-year-old, different from a 6-year-old, right? They all understand it a little bit differently. So, you've got a young child, you got to get below them. Don't tower above them, sit below them. That's a big deal. Then you're going to do something that helps them know that you're not scary, whether it be as a toddler, asking where their ears are, their eyes are, or a preschooler seeing a Spider-Man shirt going, wow, I love your shirt. Do you like Spider-Man? You got webs coming out of your wrist too? They just think now that you're cool. Now you can do, and they'll listen to you. And you can even do treatments to them because now you're not scary anymore. So, always, when you're doing anything with any level child, always involve the parents. And I always talk quietly and calmly. And what I'm doing is I'm teaching parents what's going on. Give me 1 second. I got a screaming kid in the background. Okay, I apologize for the screaming 6-year-old. Him and daddy were having fun together. So, again, involving the parents, and what you do is you always want to get that kid ready for home, right? You teach on admission for home. You're always taught that. So, we're talking to them quietly. When you're talking to a child, they're ask you a question, do not over answer them. Sometimes too much information, they don't get it. So very short explanations to them. You know, children don't realize that if they have pain, they should tell somebody. They have never been taught this. Unless you're taught, you don't know. So say if you hurt, you let me know, okay? It's okay to let me know. It's not that you're being bad. It's I want to give you something to help you not have pain. You shouldn't have big ouchies or whatever you want to call it. Again, one thing at a time, very simple. And then, do you want to get out of bed? Would you like to sit in a chair or do you just want to sit on the side of the bed? Or do you want to sit in that chair? When you give them choices, now they're involved in the care. Always use distraction. And what is distraction? Well, I did a lot of research on it because of my dissertation. And it was all about school age children's attitude and behaviors towards injections. And one of the things we do for this is we have parents hold them, okay? Whether it's small or even larger children, hold them or sit next to them and give them a hug. So they don't have that pain, fear, and stress before or after because mommy's there. But then some of the kids, I also maybe have child life involved, blowing bubbles, depending on the kid and their temperament. Distraction could be an iPad, could be bubbles, could be music, could be stickers, anything that focuses their mind away from what's going on. We do this a lot with pain. They're in pain, we give them something, medicate, and then distract them. Have them play on the iPad, right? You give Roboblocks to my grandson, he'll be there for hours and he don't care if he's in pain, right? So think about that. And always, they do get hugs, like a good job or a high five or whatever you're comfortable with. So preparing them for a child as we get older, we're as school age children and maybe the older preschoolers, we might let them examine the equipment because that big thing, blood pressure cuff, looks very daunting. So you've already gotten down below them. We've already broken the ice. They know that you're a good person. We've explained what's going on. Now let them see the equipment. Let them touch it. Let them push the blood pressure button. Let's make it fun. What number are you going to get? I bet you're going to get a number, whatever, and what number do you think? Because it's school age, even preschoolers, they know numbers. So that makes it exciting now. Now they're not afraid. If they're scared, they're afraid, and you see it, say, are you scared of something? Let's talk about it. And then it's a reward, getting stickers. We need to do this. All right, let's do it together. I've got stickers. I'll find them when we're done. Okay. Just as simple as that. Now, adolescents are a little bit differently. You don't have to go and get below their level, but you've got to break the ice. Sometimes I talk about if they're listening to music on, their iPods. I'm going to say, so what sort of music do you like? Or, how you doing at school? Have you decided what college? Depending on how old they are. Sometimes they'll even say, where'd you get those sneakers? I like them. My kids have been looking for them, or my grandkids have been looking for them. It just breaks open the ice. Now I'm human. I'm not this nurse that's always, going to give them needles and hurt them, right? Okay, after we do that, we're going to get the adolescent absolutely is going to be a part of whatever I have to do. And then we're going to be explaining everything to them because actually some treatments they do at home could be dressing changes, right? So or it could be insulin injections as they get home, right? If they're newly diabetic. So these things, explain it to them if they can, let them do it. And sometimes that being sick is hard. So tell them, do something for yourself. Maybe an older teenager say, maybe mom will let you go get your nails done, or maybe mom can take you out, for a pizza or little different things. Reward yourselves. And these things really, really help in that way. And it's also coping. Now, children, separation anxiety. Does that sound a little bit familiar? Does it sound like a discussion question? Well, separation anxiety is huge, really huge on your younger kids. We know going into a hospital depends on their age, what they know about what's going to go on, and how are they at home? Are they safe at home? Are they comfortable at home? Not all children are all the same, okay? Also, previous hospitalizations. Now you're like, well, wouldn't that make it easier? Well, what if something happened at one of those hospitalizations that they didn't like? You can't change that. And the child's going to be afraid. So the one who's been in there the most is going to have the most fear. Also, children with their family. Does the family know what they're going through? Does the family member remember to bring in their new set of jammies, or remembering maybe they could have a treat and have a hamburger from McDonald's? Oh my God, that's like amazing. Or chicken nuggets, right? That's a treat if they can get it. So that would show support. And you could tell how a child is happy, or they're sick, but are they happy, well-spoken, mannered? This is all their emotional health. The biggest stressor is when mom and dad can't stay. They want mom and dad to stay, right? The second thing that we worry about is pain. Remember, these younger children think about mutilization, right? Pain. We are those people known to give pain. So one of the things is we need to describe the pain may have and if how long it's going to last. And be honest. I'm going to do everything the best it can be, but you might feel a little bit. But it's not going to be for a long time, just a little. I'll hold your hand. Okay? That sort of thing will help this child feel better. Here we go. Separation anxiety. So, what is it all about? Number one is protest. Protest is when all of a sudden they scream, yell, and go bonkers, and they want mommy, and mommy has to go home. She has to go to work. She has to take care of the other child. She has to go. So these kids, about 6 to 8 months is when they know when mommy's not there, and they want to go back to mommy when even somebody takes them out of the arm. Okay, so this is something that we know they're going to go through first. Well, then they're going to be like, well, all right, mommy's not here. I'm tired of crying. Nobody's listening. I give up, right? Basically. Then it goes into despair where they sort of regress. They start sucking their thumb. They be incontinent when they've been potty trained forever. They don't want to play. They lay in bed. They sleep. It's almost looking like a depression of an older child, but it's just the acceptance, the regression of nobody wants to be here with me. My mommy didn't stay, right? That's the way they feel. And then they're like all over it. Now the nurses are fun. They're doing well. Nurses are explaining. They're being in there as much as they can because they know the kid's alone. If they can and the kid's not infectious, bring them out to the nurse's station and let them know what's going on. We do these things all the time for kids that can't have there because parents have to work and have other kids, right? Well, then all of a sudden, parents come back and they're like, oh, I don't even care who you are. I'm all right. I've got my nurses. And it does happen that way. And it's just part of it. So they become more involved in themselves and their toys and stuff, and really are not interested in mom because mom's going to leave again. And then they'll have to cry again. Right. So those are the three stages. Now, as I said, fear. They're afraid of people who give pain, for sure. They're afraid of anything that needles or sticks in them or on them or squeezes them because most of them have never had it done before. So they're afraid of it. So again, good explanations on their developmental level. So when they're in a hospital, they have to do things at certain times. You walk in to do your set of vital signs in the morning, afternoon, evening, you need to get them done. The child doesn't really have an opportunity to say, yeah, I don't want to do it because it's something that has to be done. Again, the nurse will explain it, et cetera, et cetera. But again, they don't have no self-control. They don't at all. They're in the hospitals. Many of them can't wash their hair. They can't put their cute clothes on, their cool clothes, as my grandson says. And that would make them feel sort of less than. So self-esteem. Some children, depending on surgeries, can't get up and move around like they should, so they can't move and do normal activities. It's frustrating. And the one thing that we need to do is try to understand when parents do those ritual things, right? What do they have for breakfast? When do they take their nap? When do they do bath time? All of these things, the way they do at home, if we sort of try to do it in the hospital when we can, it does help them feel more comfortable, right? Especially your toddlers. Toddlers love to be in a ritual. They like the same thing every day. It gives them comfort. So regression, we know I've talked a little bit about it, but here's a little bit more. Regression is part of what they do in despair on separation anxiety. But regression, you will see them, they don't want their cup. Oh, they want a bottle now. Okay, they haven't had a bottle in a year, but they're starting to regress. Again, I told you about the bowel or bottle control, and then now they don't want to walk. They want to be carried, or they want to be put in that wagon that they saw outside, right? So these are things that they do, and many other things to regress. Even their voices get more baby-like. Have you ever heard that? How do we take care of regression? Well, regression is something because a child is afraid. They're fearful. They're stressed. They're in an environment they don't know, especially if they're in even a doctor's office for a period of time. You have to do an immunization, especially in the hospital where they have to stay there, right? So it is the nurses, the nursing staff. It's not doctors, it's nurses. We're there all the time. We're there 24 hours a day, 7 days a week. I mean, that's nurses. We don't get that, one day off, nobody works that day. Well, we do every single day. So if a child is there and you see these signs, sit and talk with them, find out what's going on, and don't punish them for feeling bad or regressing because it's giving them the comfort that they do need, okay? When a kid doesn't feel so stressed anymore, feels more in control. We're doing things like home. We're not, sitting and telling them you're a bad boy, you should do this. And then now they're feeling praise. They're going to do so much better. Okay. And we need to praise really good behavior. All right. If they're doing things you don't want to see, you ignore them. It's just like temper tantrums. Ignore them unless they are bringing harm to themselves or others. So let's think about this, a critical thinking question. The mother of a 2-year-old patient says that she has decided not to visit for the next couple of days because it upsets her daughter too much when she has to leave. She says that it will be easier for everyone if she stays until it is time for her daughter to be discharged. How would you respond to that? What's going on? Anybody? Should mom stay at home?
Still think she should come. I mean, I understand it makes her upset whenever she has to leave, but she still should be present and involved too.
Right, because she needs to see the teaching that we're doing all the time, but she needs to know why the kid does that. So tell her it's just part of normal and that your child is acting normally. And yes, it is difficult for you and your child, but it's hospitalization. We will try to make it easy, but your child does need to see you, and you need to come in so that we can make sure you understand your child, how to take care of them the best way. Very good. That was an excellent answer. Now, pain. Pain is something that years ago we didn't really look at as closely as we do today in children. Children, as I said, they won't admit to pain unless you tell them. They can tell you. They're like, well, I'm in pain, all right. I guess it's the way it's supposed to be. They don't know that, hey, give me something for pain. I mean, adults know it and they'll ask right away. Not a kid. They don't know it. You know that old saying, pain is whatever they say it is for whatever age child, from child up to an adult, okay? One of the things that keeps them from admitting it is they're afraid they're going to get that, what we call a pinch or a shot or an injection. They don't want that needle, right? So sometimes you can say, I can give you something for your pain. And you see that tube that's already there in your hand? Well, I can put it through there and it won't hurt you at all. And it will take all your ouchies away, depending on the level of the child. So let them know that they can ask and don't let a kid be in pain, okay? Infants, remember we have FLAC and nonverbal children also is FLAC. As I said, an 18-year-old child who's nonverbal, let's say cerebral palsy, that child can't tell you what's going on, but the FLAC scale is great to use for them also. Remember why they have pain, and remember it's not just all medicine. It could be, for instance, you have an infant, let's say a toddler, a preschooler, who just had appendix surgery, and you walk in and their bed is flat. Can you imagine how their belly would feel just positioned? Elevate the head of the bed, put a pillow underneath their knees, bend it up so there's no tension on that belly. What about a sickle cell child? How about putting heat or cold, whatever the kid likes? I like cold on my rheumatoid arthritis. Most people like warm. So find out what they like. Could be positioning, could be getting them out of bed. It could be as simple as hot and cold packs. Maybe even just rubbing their back. Remember, there's so many other things besides just medicine, and then distraction also. There's what a FLAC scale looks like. We look at the face. Their legs are like going nuts. We know there's a problem. If they're just sitting there laying, not moving, oh, that kid hurts, all right? If they're normal, then you can see if they're squirming, like for instance, moving their head and banging it, it's probably an ear ache on an infant, right? So all of these things, arched, that's reflux in an infant. So there's things that they can show you. And of course, cry, and if you can console them. I mean, a lot of kids will cry just because you're a stranger, right? Stranger danger. But no, If you can console them by giving them a pacifier, or, just, holding them and patting their back or whatever, and they're stop crying, they're consolable. Now, as a kid gets to preschool at age 3, you start the FACES scale. And I have seen kids use this, and they are so honest with their pain. Adults are all 20s, right? How much pain do you have? Oh, I'm at 20. All right. Well, a child, a 4 or 5-year-old child, will point and it will be a number 6, or it'll be number 4. By looking at the faces, they know how they feel, and it works really well. Every time I did a FACES scale on these younger children, I always smile because they are so real. It's a real pain thing. As I said, besides all the moving and all of that things, remember distractions. CP kids get this imagery thing. It's like lights and things around them, and it just it gives them comfort, and they lay it on them and they see it moving. Relaxation, older children, and then just, thinking about things that can distract them. I think kids today, give them an iPhone and let them play a game, right? A 3-year-old will do it. I know my grandson at 6 uses my phone better than I can ever. And when I can't figure it out, I say, hey, Christian, could you figure this out for me? Distraction. Then they forget about all of it. Remember, children, just like your older adults, they're the same thing. Now, you've got the older adults, they've damaged their organs, right? Through whatever, being old. Young children just have immature organs. They're about the same. Remember, the way that it's brought in, it's metabolized and excreted are all delayed. Well, what does that mean for nurses to know? Well, we need to look for side effects a lot closer than adults, that middle age portion, okay? Those children can get the buildup of drugs. It hasn't been excreted, and their levels get so high, they can have side effects. And I'm going to give you a good example. Vancomycin, CIN, aminoglycoside, right? Really, really strong antibiotic. And most kids in the hospital, that's the one that they're going to get for staph. Remember, you had to take a peak and a trough level, measuring levels and time in between doses? Well, really closely in your children, because they could get toxic levels, and then what will happen? It's ototoxic, it'll kill their hearing, and nephrotoxic, it can kill the kidneys. So we have to be careful, okay? Now, drugs that are used for pain. Remember, pain medicine is not just always morphine, right? Remember, there's Tylenol and acetaminophen and ibuprofen. We only give acetaminophen up till 6 months old, and then we can add in ibuprofen. We do not give children younger than 6 months ibuprofen. It has to do with platelets, aggregating and bleeding sort of things. So we don't give it too young, okay? And remember, if a child, we know they're going to be in pain, remember, do that preventative pain control. Give them the medicine before. And it could be the acetaminophen or the ibuprofen. And then later on, if you see them more in pain, give them that Motrin. Opioids, what are side effects? What do we have to worry about? We know acetaminophen and your NSAIDs, your ibuprofen, they're really good for many things. Children really don't get a lot of this when they're young, so it works really well. Now, opioids, morphine, the biggest thing is respiratory depression, right? So we have to watch it. Now, what do you need to be aware of if all of a sudden your child goes into respiratory arrest and you just gave them some morphine? Well, you need to know naloxone needs to be at close. Usually they have it in medicine carts or in the medication room. Go and grab it, and then have the doctor, of course, calling the doctor, telling your charge nurse, and be prepared. So the antidote for opioids is naloxone. Fentanyl is something that's used more than you really realize. Fentanyl is an extremely potent analgesic. It is either given intranasally, we're doing it for children, works great, there's no pinch, right? Or we can give it IV continuously. We do these on the tiny, actually premature infants, low dose that they're not in pain, because we're, just touching some of these children can hurt them with a little bit of sedation. A continuous drip, I've seen it for many, many, many years. It's an old drug. Now, the thing with fentanyl, it's strong, like I said, right? 50 times the normal of just something else. It's that strong. So it starts when let's say you give intranasal. It's all those capillaries bring it in, and it acts really quick. Soon as it's into the body, if it's IV, it's like, whoa, and you're down. But it lasts for like an hour or two, very short duration. That's why they use it a lot for procedures, because we get it out pretty quick, okay? Now, a lot of times pain relief is big. Let's say we have to do things like suturing. We put on some sort of cream jelly. Emla is the big name brand, but it's basically lidocaine and prilocaine sort of things, or Let is another thing that we use. There's all different names of them, but we put it on the skin for whatever. We do these for spinal taps too. We do it for suturing wherever it is. So wherever we need to have numbing and we're not worried about blood flow, that's the big deal, because it constricts everything, all right? So you don't want something that's falling off a finger and put it on the tip, because you're going to stop blood flow. But Emla cream, Let cream, whatever, use them because it decreases the pain and they feel touch and they don't feel pain. Now, conscious sedation is used quite a bit in the ER. I used it a lot for really bad fractures in children, bilateral wrist fractures. Legs, not as much, usually wrists. And I've done bilateral wrist fractures before on both radial and ulnas. It is something that we give IV where they're still breathing on their own. Usually put a nasal cannula in, and we connect it to this monitor, which shows us how they're breathing. It's called an end tidal CO2 monitor. We can see, are they breathing, okay? So they're there, but they're not. They don't remember anything, okay? In conscious sedation,
Do anybody else hear her?
No, I think it's
Girl,
frozen.
no, what the heck happened?
Yeah, she's frozen. She's frozen. Oh, okay.
Well, class over with. What the heck?
Maybe she got the same electric problems.
Thank you. My internet just shut off and came back on. I apologize. So the last thing I just said about conscious sedation was that when they're done, what's great about it, they're not in the OR, right? All right, another thing we need to be concerned about is how to talk to these children. Some children, parents don't come from a language that you're aware of. So we really need to be cognizant of that. Some of them just try to talk to you, all right? Some of them can't. So what you need to do is use the blue phones. Do not use somebody else in the family because they
Miss Bogart,
yes.
can you share your screen?
Is that what happened? Yes, ma'am. Thank you. So with language, do not use a family member, even a teenager. They're going to interpret what the parent says with their own voice. So your best thing is to do is use those blue phones, okay? They work well and they're quick and they have every language. When we talk about children from a different culture, there's a lot of things that we don't know, and you don't have to know everything. What I have learned, parents respect you when you ask. I know that, your culture and your religions are different than mine. Is there something I have to be mindful of when I'm taking care of your child? Oh my God, they'll give you hugs because now you've respected who they are. Some of them has to do with you can't have a male with a female patient, no matter the age. So no male nurses. Could be vegetarian, or they don't eat pork, they don't eat beef, they need time to do the religious stuff during the day. These things are important to these children and parents, so you need to respect it as long as it's not interfering with your medical care, okay? So the bottom thing, showing cultural sensitivity decreases anxiety for everybody. So now they know that they're respected for who they are. You don't have to believe in their religion. You only need to know your own, but you need to respect parts of theirs. Whether you think it's right or wrong, it's their culture, their religion, okay? Now, there is a lot of people, I know in my experiences, fathers from the Middle East. I have learned I'm not going to directly look right into their eyes and be close to them and touch. They don't like it. Okay. But I've learned that from experience. So always keep personal space until you know who that family is. I'm a hugger and I'm a kisser, I'm a squeezer. I mean, that's just who I've always been. But I have to remember culture. Remember, smiling is not always happiness, okay? Sometimes it's just being respectful to the nurse, or not smiling is being respectful. Again, you can ask these questions. As I said, touch, remember, not touching without permission, even the children. I'm going to touch you on your arm. I'm going to tickle your belly and listen. Those things, very, very important. And sometimes the focus is make sure you bring back what they're talking about. Sometimes they'll go off and it's just too much information. Okay, so let's find out what we need to do right now. Now, parents, you have to remember they're putting their kid in a hospital. They're putting their everything in your hands. And many of them have to leave, like I said. So you need to let those parents talk about, because they might cry, they might be upset. You might see them hesitant, feeling like less than because they can't be superhuman. They got other kids, they gotta work, and things gotta get done, and you're gonna see things. So allow that parent to describe it. Some of the times where I get a new parent in, especially younger infants, and a kid who's been sick for a week, I say, you're amazing. This kid's been really sick for a week. Have you slept and you're working and taking care of him? You've done a great job. He's in the hospital now, and I promise we're going to take care of him. These are things the parents, you'll see their shoulders go down and go, she understands me. Okay, I can leave my child with her. These little things you say make your life as a nurse a lot easier too, okay? So communication. It's like I say with me, talk with me, I can help you. I talk with my parents, they're gonna help you too. Nurses are the psychologists in a hospital. You are there in between mothers and stepfathers and, fathers that are coming in because their kids are sick, but they're with another. It's just all of these things are going on, right? So you have to sometimes, have them be in some mood that's conducive for the child, right? So sometimes nurses have to stick in, right? You need to be prepared. What if they're doing things to your child and they're upset and stressed? Again, say, this must be difficult on you. Open-ended question. Let parents respond to it, okay? Children get anxious. Well, so do the parents. So remember talking to the child too. So hospitalized child, the poor thing, they're frustrating. They don't want to be there. They want mom and dad, they want to go to bed with mom like they do every night, right? Or, they want to have their movie before they go to bed with Nana, like me and my grandson. I mean, they don't do their normal routines. They get really frustrated. So know that. So maybe little special things for these kids, right? Those little rewards. They're gonna miss their kid, their parents, and they don't like their daily schedule disrupted. That ritualism of every day almost the same. What is our job as a nurse between parents, the child, is make sure that the parents and the child have a good relationship, they can speak to each other, and that we're teaching them as much as we can. You think a 4 or 5-year-old child doesn't know, let me tell you, they can be your best person to take care of themselves with mommy just watching over them, okay? And sometimes parents, as I said, can't be there. One of the things we can do is have the nurse scheduled there. If they're there for 3 days in a row, give that kid to that one nurse in a row. That multiple nurses confuses them too. Somebody else to learn and to trust. So sometimes we know that adjusting to an illness can be difficult. A great example is diabetes. You've got an adolescent who all of a sudden is diabetic. You need to have that child participate in it. And you need to have them learn how to work with it and listen. There's a lot of listening. When we're doing things, for instance, with diabetes type 1 and it requires insulin, show the parents insulin, how to test blood sugars, have the kid do it, write their own thing, or say, remember 11 o'clock, do your blood sugar, I'll be back to check it. And if they've done it, yeah, great job. Even teenagers want to be told, good strokes. I like it when people tell me I do good. I mean, it's just part of life. You want, to try to be the best you can be. So you have an 8-year-old who's admitted to the oncology unit for his first round of chemotherapy. While the family is visiting, the nurse observes the patient's 4-year-old sister's crying and repeatedly asking her parents to give her a bandage for her owie. Remember, that's the age of band-aids. The mother tells the child that she is fine and to stop crying, as so not to disturb the other patients. What does the child's behavior suggest, and how does it affect the patient's nursing care plan? Somebody else to involve, isn't it? What would you do? Would you give him a Band-Aid? The 4-year-old, would you give them a Band-Aid? Absolutely. Now she feels involved. She's scared for her brother. Her brother's there, admitted, and they let her come up. And she's this owie thing. She wants a little bit of, think about me too, but she's worried about her brother. So have the 4-year-old as much as you can on her developmental level being involved and putting a Band-Aid and say, would you like a Band-Aid for your brother too? I bet you he might have a boo-boo, right? It helps. Those little things are priceless. Roommate selection. You have 2 infants and you have upper respiratories on both. You would make sure, are they all up to date with their immunizations each? If not, they can't go together. Adolescents, you want both what we call clean and dirty. It's not necessarily dirty, but infectious and a clean case. A clean case is going to be diabetes and sickle cell. They're clean. There's not an infection going on here, right? So those 2 kids could go together. Try to, always same sex around the same ages as possible. You put a 16-year-old new diabetic in a room with a 1.5-year-old who's crying and screaming and yelling. That's not fair to the kid. So room selection is one of the charge nurse's big dilemma. How do I get kids where they need to be? And that's why there's a lot of movement of children from room to room. That's why we never do meds by room number. That's why they change, to get kids in where they need to be together. Confidentiality and legality, well, HIPAA for sure, but what about an 18-year-old adolescent goes into the ER for treatment? Does he need mom to sign his consent? No. 18-year-olds, awake, alert, oriented, cognitively aware, signs their own consent. But guess what? You have to ask that 18-year-old to tell the mother and father what's going on. May I speak candidly and open in front of your parents? Because many of them will show up, right? So you have to get permission there. There's something different we don't think about. We think of other things. Married minors or minors in military, they are absolutely emancipated. You can have them sign their own consents. And there's the emancipated, teenagers for whatever reason there also. So one of the things about medical care in adolescence is this down here, where they can get medical assistance without the parents knowing it for sexual transmitted disease, contraception, pregnancy, abortion, and drug use. You don't need mom to sign a consent there. One of the questions that I've always seen on HESI was, an adolescent asks you for information on the birth control pill. What do? Well, you give them information orally and written, and you don't have to tell parents. The only time you got to talk to a parent on a younger child than 18 is that child who's in harm to themselves or other. So discharge planning, well, like I said, starts on admission. We know that going home, they need written instructions to know what's going on. They need to know exactly what they have to do, who they need to call in case of emergency, and then they need to understand what's expected. If you have tonsils and adenoids, let's say as an outpatient, they're going to go home. Okay, when should he feel better, right? Things like that you need to know. How to feed them, what to feed them, when to feed them. So parents need to be also aware of a lot of behavior problems in children. Remember, children, they're going to have things like nightmares and regression in the hospital. Mommy and daddy have to leave, etc., right? Any sort of regression. As I said, anybody from the family the kid trusts that can stay would be a good thing. Also, as you're going home, you're going to be telling them about, wow, you did such a great job. I know how hard this was. Because if they come again, they're going to say, well, the end of this experience wasn't bad. She gave me extra stickers and she, whatever, right? Always be consistent. If a kid is supposed to stay in the room when they're coming out, always, you need to come back to your room. Here, give me your hand. Let's go with me, and be consistent with it. So then they get it over and over again. They understand. Kids love repetition. Always be truthful. If it's going to hurt, let them know. Like I said, always give appropriate stuff to play with for kids. And they do need time, that we're going to do nothing to them and they could just play with clay or color or watch a movie or whatever. Okay. And then always listen to them. If they have any questions, let them know, and be aware of those children who don't have the parents there. Okay. Because you're going to be in that room a lot more. Legal and ethical considerations on discharge charting. Remember, you need to say who they went home with, how they got there, and you need your last set of vital signs and instructions that were given. This is all legal. They can say that the nurse never gave me and I didn't do that and the child, died at home. And it can happen like that. So be aware that it should be documented in the nurse's notes. It's the last thing you do. In home care, you have many kids and adults go home and they need home care. They might need continuous PIC infusions, intermittent antibiotics, treatments, physical therapy, occupational therapy, speech therapy. These things can all be done at home. Now, if it's something that a kid can still go to school with, you have school nurses that can assist. It could be maybe they need an oral antibiotic at 12 noon. Well, as long as the nurse has proper instructions, they can help. They don't have to stay at home. A 16-year-old high school junior and varsity athlete is admitted to the pediatric unit after a car accident. She has head and facial laceration and a fractured femur. During the initial assessment, she avoids eye contact during the conversation and is withdrawn. She also says that her junior year has been ruined and that she cannot possibly go to the prom looking like this. What developmental concerns influence her recovery, and how can she be included in the nursing care plan and goals? This happens. This is a reality. What do you think? It's been a long time since I got to junior prom.
She's worried about her appearance. She's worried how other people are going to look at her. So.
Absolutely. What if we turn it around and say, hey, you should have died in that car accident and you're superhuman. You're like the bionic woman, right? Let's turn it into, why don't you put
positive.
Put a cape on and go, because you are amazing. Now, do you see how that just flipped over? See, very good, Tanisha. Thank you. So that is that. Any questions for me at all? I apologize for my internet here. I mean, she pays the most internet in this house. I don't know, but it sometimes does happen. Again, I will have your stuff due and your grades posted for you by tomorrow about 2:30-ish, soon as I can. You all didn't do that bad. That was the ranges I told you. Nothing left less than 70. All easy comebackable. Remember, if you need me, please make an appointment and I will sit on you 1-to-1, 2-to-1, 4-to-1, whatever you want, and go over the exam. Okay. Thank you, everybody. Yes.
Professor, just talk to you after the class, please. Just
not a problem. Not a problem.
When everybody's left, I want to talk
Have
to
a great weekend, guys.
No, don't